Hello again. For many years I worked as a paediatric pathologist at the Children's Hospital at Westmead in Sydney, and during my time there I encountered many retinoblastomas and other paediatric eye tumours. In the next 20 minutes we will cover these topics, starting with why enucleate and then logically following the specimen through, communicating with your pathologist, how to spend the specimen, some histopathology, the staging, the identification of pathologic high risk factors, retinoblastoma mimics, and a few other paediatric orbit tumours. The current trend for eyes with retinoblastoma is a marked decrease in enucleation as eye-preserving therapies have become increasingly favoured and effective, especially for intraocular disease. Over the past 2 decades, advances in intravenous chemoreduction, intraarterial chemotherapy, and focal therapies like laser and cryo have led to higher rates of globe salvage and reduced reliance on primary enucleation. I found this to be true in a quick audit that I did of specimens at the Children's Hospital at Westmead. I can think of at least 6 reasons why enucleate a retinoblastoma globe. Type into the chat 1 or 2 reasons. I'll wait. These are the reasons that I thought of and are commonly described in the literature, particularly high clinical stage and extraocular disease. Of course, they're related. Sometimes we get patients from the Pacific Islands, which will be difficult to follow up, so an enucleation is deemed the best primary therapy. And of course, if there is no visual function, particularly due to chronic retinal detachment, or often failed local therapy, then the globe comes forward for enucleation. So you have enucleated the globe. It's surprising what clinical information can be missing from request forms. So, excluding the patient identifiers which are on the sticker, what clinical information will you provide? Think of 3 things. Type them into the chat. These are the minimum things that I need to know to properly assess the globe. Just last week, I had an eye specimen that did not specify the side. Knowing the prior therapy helps me locate any minimal residual disease which may be hiding in sequestration sites. How should you send the specimen to the laboratory? Well, fresh. That means not put in formalin. Why? Because we need to extract fresh tumour for genetic studies. The orientation is also helpful, either with a suture in the rectus muscle or a mark like this globe. The genetics. I have found a 10-minute video for you to watch in your own time. I will not play it now. I do have a 1-minute video I made in my lab showing how we harvest fresh tumour. Harvesting fresh retinoblastoma from an enucleated globe. Ink the optic nerve margin before taking the section. You'll need a marker pen and sterile forceps. I find ripple foam is very useful for holding the globe steady to stop it rolling away. The superior calotte is indicated with a black marker and is incised with the tip of a scalpel blade. The superior calotte is further opened with scissors, leaving a hinge posteriorly. In this case, the tumour is anterior to the equator and is easily seen through the pupil. A tumour is harvested using sterile forceps and a new pipette. Place the tumour in a clean freezer tube. To learn the basics of the histopathology of retinoblastoma, we have created a CuraCloud interactive module on retinoblastoma histology, and Diane explains the histology in a short 2-minute video with follow-up activities. It's best you do the module and understand the histopathology with active learning. Next, we are up to staging. You will be familiar with the ABCDE system of clinical staging of retinoblastoma. This is to guide management, including whether or not to enucleate. The pathology report on the already enucleated globe uses a different system. The stage guides the need for further therapy, and there are many details here in text. Let's do a visual overview. There are 4 stages in the pathological staging system. The little p means pathological stage. T1 is confined to the eye, with no choroidal or optic nerve invasion. The size of the tumour does not matter. Dotted line is the lamina cribosa, and the maroon colour represents the choroid. In PT2, minimal optic nerve, that is a pre-laminar invasion and choroidal invasion of less than 3 mm is allowed. In PT3, the choroidal invasion is greater than 3 mm in size, which is termed massive, and there is post-laminar invasion of the optic nerve. In PT4, the tumour is at the optic nerve resection margin or there is extraocular extension. What is not included in this system is the anterior segment involvement, or not, which is also a prognostic factor. Next, let's look at some actual globes I encountered while at the Children's Hospital at Westmead. Good example of leukochuria. The tumour fills the globe, but there is no choroidal or optic nerve invasion. What stage is it? It's PT1. Remember, size is not a staging criteria. In this example, look at the optic nerve. The tumour is at the margin. This is the highest pathological stage, PT4. This will require additional therapy. This globe was post-chemo, cryo and laser and recurred in the anterior chamber. You can see it here. There was also retinoblastoma hiding in the ciliary processes. It was very small in size, so stage PT1 because there was no choroidal or optic nerve invasion, but the poor prognostic factor is the anterior segment invasion. This patient had a diffuse fat enhancement on MR prior to enucleation, which was suspicious for orbital extension. However, the tumour was confined to the globe with minimal choroidal invasion, and the tumour showed a lot of necrosis. The orbital fat enhancement was due to orbital and scleral inflammation as a consequence of massive intraocular tumour necrosis and the release of pro-inflammatory mediators which diffuse through the tissues, causing sterile inflammation. This is not tumour or infection in the orbit. So this tumour shows choroidal invasion. Here you can see the retinal pigment epithelium is this dark layer, and here's a closer up. It's greater than 3 mm, so it's massive, therefore at least PT3. But there was optic nerve thickening. Is it also a T4? So histology shows the thickening of the optic nerve is due to hemorrhage, not tumour. Therefore, it's still PT3, margins clear. Here's another example of anterior chamber invasion. There's little small flecks that I could identify. There's also massive choroidal invasion. See how the tumour is below the retinal pigment epithelium, expanding the choroid. And the histology shows exactly what we saw on the macroscopic specimen. Massive choroidal invasion without optic nerve invasion, PT3. So those were some examples of different stages. Next, let's decode the pathology report of a retinoblastoma. Typically, cancer reports are in a structured format. This helps everybody find the minimum data set. So, tumour type, retinoblastoma, of course. There are some typical words associated with the retinoblastoma tumour and an explanation of endophytic and exophytic. Then there's always a comment on the optic nerve, whether there is tumour, no tumour, prelaminar, laminar or postlaminar, or at the margin. There's a comment on scleral invasion, extrascleral invasion, whether there's choroidal invasion, of course if there is it massive or not, and a comment on the anterior segment invasion, whether it's present or absent and what it involves. So, we have enucleated the globe and read the report. What are the risk factors in the pathology report for high risk of progression? Write at least one feature in the chat. There are three main things to remember, but how to remember them? So if you think about it like retinoblastoma escape routes, and this is the concept is a visual mnemonic. So retinoblastoma can escape out the front, which is anterior segment invasion. It can escape out the middle, which is massive choroidal invasion, or it can escape out the back, which is optic nerve postlaminar invasion. So when your report has one of these or more of these high risk factors, then additional therapy will be required. Okay, what say it's not a retinoblastoma? List 3 mimics. Type into the chat. Well, these are the typical ones that are found in most textbooks. We don't get enucleations for the last 2, but sometimes a Coates disease comes out. Coates disease is the most common mimic. It's a vascular anomaly characterized by abnormal retinal vessels that leak exudate, causing retinal detachment. The age, usually boys, average of 5 years old versus retinoblastoma, where the average age is 18 months. Almost always unilateral, and the key feature is the massive subretinal exudates, which are lipid deposits. It also doesn't have calcifications on CT or ultrasound, whereas retinoblastoma often does. So that concludes the globe tumours. Let's turn now to the orbit. There is a differential diagnosis of this orbital mass in a child. Type 1 possible diagnosis into the chat. Here are 3 tumours or mass-forming lesions that I will discuss next. And so you can see we've got a combination of a primary tumour, a metastasis, and a benign vascular lesion. So back to that CT scan, either of these cases of rhabdomyosarcoma could present with a radiology similar to this. Histologically, they can also look quite similar, the 2 different types. They're both composed of masses or sheets of undifferentiated small round blue cells. So it's a tumour, but what sort? How do we know it's a rhabdomyosarcoma? The types of rhabdomyosarcoma are distinguished genetically, with the alveolar type having this T213 translocation, whereas the embryonal rhabdomyosarcoma does not. Embryonal type rhabdomyosarcoma is more common in the orbit and in younger children. Here we can see these tadpole-shaped cells, which are primitive rhabdomyoblasts. The pink material is actin and myosin filaments of a primitive skeletal muscle differentiation, whereas in the alveolar rhabdomyosarcoma, these are undifferentiated cells. The reason it's called alveolar is because the groups of cells tend to become discohesive and form alveolar, as in lung, type spaces. It's purely descriptive. If the tumour doesn't show this primitive skeletal muscle differentiation, we can tell it's differentiating to rhabdomyosarcoma by doing skeletal muscle markers such as desmin and myosin. So, what is rhabdomyosarcoma? Although the name suggests a tumour arising in skeletal muscle, this is not true. Instead, it arises from primitive mesenchyme and differentiate towards skeletal muscle. Most rhabdos arise in the head and neck. Think about it. In the sinonasal tract, middle ear and genitourinary tract, these areas don't contain skeletal muscle, and although the orbit contains extraocular skeletal muscles, rhabdomyosarcomas do not arise from these muscles. I recall a few years ago, I was asked by a journal to be a peer reviewer of a case report about rhabdomyosarcoma. And I opened up the PDF to read it, and the first sentence was something like, "Rhabdomyosarcoma is a tumour arising from skeletal muscle." I read that, and I knew that these people had no idea and did not understand pathogenesis. That case report was an instant reject. So, now you know, and you won't make that error. Next up, metastatic neuroblastoma. This occurs in late-stage disease. Children are known usually to have neuroblastoma elsewhere. Often it's hemorrhagic, and it causes periocular ecchymosis, and this appearance is termed raccoon eyes. Neuroblastoma is another embryonal tumour made of small round blue cells. Often we need immunostains to distinguish it from rhabdomyosarcoma. Primary neuroblastoma arises anywhere along the sympathetic chain, mostly the adrenals. We won't get a primary neuroblastoma in the orbit. However, the orbit is a relatively common site of metastasis in children with disseminated disease, occurring in 10 to 30%. And the last one I'm going to discuss is infantile capillary hemangioma. Infantile capillary hemangioma are the most common vascular tumour in the orbit of children. The histology on the left was from a baby who had a rapidly growing orbital tumour displacing the globe. It would have looked something like this image that I got from this article here. The family lived in Indonesia, where they had limited access to diagnostic services. Clinically, it was thought likely malignant, so it was excised. The parents put the specimen in a jar in their suitcase and they came to Singapore for diagnosis. I received the case when I was working in Singapore. It's not malignant, but composed of these vascular spaces containing blood. It's an infantile capillary hemangioma, and in some cases it can be treated with propranolol. They start off in the first few weeks after birth as a relatively solid lesion, and the vessels become more dilated with maturation. In this case, where the vascular lumen develop quite prominently, this is a relatively mature specimen. So to conclude, this is what we've covered. And if you compare this list to your ocular pathology curriculum standards, all of these sections are included and are examinable. And you do have that video and CuraCloud lesson on retinoblastoma to complete your learning.